Cervical manipulation can be powerful when it's selected well, screened well, and integrated well. Here's how to make it safer, ethical, and effective in a modern plan of care. Today, we'll cover 5 practical areas for safe, skilled care. 1. Indications and goal setting. 2. Risk screening and consent. 3. Decision-making. Manipulate versus mobilize versus exercise. 4. Dosing, aftercare, and documentation. 5. Interprofessional communication. Best candidates often present with mechanical neck pain, tension type, or cervicogenic headache features, and segmental hypomobility, with no red flags. Set specific, measurable short-term goals to enable function and rehab participation. Goal 1. Pain modulation to enable exercise participation. Goal 2. Short-term ROM gains to restore driving or desk tolerance. Goal 3. Decreasing headache frequency and intensity. Use outcome tools such as NDI and PGIC plus ROM and irritability profiling to track change. Screen before every session, especially with irritability or history changes. Consider red flags first. Red flags: recent trauma, high fracture risk or severe osteoporosis, malignancy, infection, inflammatory arthropathy, unexplained night pain or weight loss. Neurosigns: progressive deficits, bilateral or multimyotomal involvement, myelopathic signs or bowel bladder changes. Avoid manipulation and refer. Vascular neurovascular symptoms to screen: sudden severe worst headache, diplopia, dysarthria, dysphagia, drop attacks, new unexplained dizziness. Also consider medications and medical comorbidity, anticoagulation, connective tissue disorders, severe atherosclerosis, uncontrolled hypertension. Document screening, obtain informed consent, and integrate manipulation only when it fits a broader plan of care.